private practice. So he's going to really bring you guys up to speed a lot on, it looks like real world, and go upstairs with you guys, kind of talk about real world stuff and what it means to build a practice, things like that. And I'll brag on this guy for a second, because if you want to build a practice, you got to be like this guy. This guy was the one who would never go home without checking on all his colleagues first. He was the type of guy, when I was on first go, would be coming down to the ER. I'm like, what are you doing down here? And he's like, well, I heard you had a bunch of consults, so I just see if I could help out. He was the kind of guy, when you were on second go, he knew you'd want to do that case, but he'd still come in. You good? You got anywhere to be? You sure you're all right? So if you want to build a practice, you want to model it after this guy. And just like his Navy training, never leave a soldier behind. He's the type who's always going to make sure all his partners are taken care of. So and Dr. Reagan also has his husband and father of two young children, Wills and Jane Claire, that are, my gosh, growing, and we're just super excited to have them here. And so let's welcome Dr. Reagan.
Appreciate it, Jeremy. It's good to be back. I was thinking, I feel like I've been back in the building since I graduated, but I'm not positive. A lot of new changes. When I was here, all the sixth floor was just the step-down unit. There were no ORs or surgery or any of that kind of stuff. So it's good to see the progress that's happened since I left. So, Jeremy already told you I am Stan Reagan. Graduated in 2011. Now this is when I was here. We were here. This was 2009, and it has not always been as lopsided as it was Saturday, and that's when Dr. Duddy was still getting haircuts. So I don't know if he's in here or not, but I had to say it, Jesse. Sorry. All right. So what am I going to talk about? Basically, just give some advice based on my experience. As Jeremy alluded to, I left. I'll get into it more in a minute. But I left here, the Navy 4 years, and then I went to private practice. So no fellowship training. So basically, what I have to teach you is going out in the real world and going to work, and the things you learn through that process that you don't necessarily learn in residency, and you don't know what you don't know. So try to at least clue you in on some of that stuff. Understand some of the opportunities of a practice. This is a academic setting here. Obviously, every practice is not set up this way. Encourage you to continue to keep learning even after you leave here, because there's a whole lot of things I do differently now, or that I do now, that I never saw in residency. I'll go over some of that later. Maintain a network of people to talk to, keeping things in balance. And again, this is a unique environment here. A lot of y'all, most of you, I'm assuming, came, traditional college medical school residency, and so these are just things that you just don't get exposed to here. Not bad, just different. And all these things will affect you in one way or another soon. Even if you stay in academics, you need to know what's out there. And obviously, if you're going out into a non-academic private practice type setting, hopefully I can clue you in on some things that you'll be glad to know, just to make your life better and have a better practice. So I'm from Jackson, Tennessee. It's right in the middle of the western third of Tennessee, between Memphis and Nashville, right on I-40. Graduated from University of Tennessee at Martin 2001, med school in Memphis 2006, graduated from here in 2011. I was in the Navy for 4 years after that, till 2015. Then I moved back to Jackson to join West Tennessee Bone and Joint, which is where I am now. And then Jeremy mentioned my wife, son, and daughter. So this is my graduating class. It was me and Sincere and Hester. Hester's in Fort Payne now, Alabama. He was it Calhoun? I always forget. Or Carter. Yeah, he's from Cartersville, practicing Calhoun. And then went to Gadsden, Alabama for a little bit, and he's in Fort Payne now. Hester also did general, like I did, and then y'all know Sincere. So, all right, my time in the Navy. How did I end up in the Navy? I was part of what they call the Health Professions Scholarship Program. They paid for all 4 years of medical school. I got a stipend every month, which helped cover rent and that sort of stuff. They paid for books and stethoscope and all that stuff you got to have. And then, because they paid for 4 years of school, I owed them 4 years on active duty when I got done, and 4 years in the reserves. Now, I got a deferment to do a civilian residency, which is how I ended up here. I graduated med school in 2006. At that time, we were in the middle of Iraq and Afghanistan both. The Navy was anticipating a need for more orthopedists than they could train in their programs, and they do have 3 residency programs throughout the country. And so in 2006, they gave 10 deferments for people to go do civilian residencies, which is what I wanted to do anyway. And so I came here, did my 5 years, got paid just like y'all did nothing with the Navy. I think Dr. Alvarez got a letter once a year, basically said, hey, is Reagan still there and in good standing? And they said yes, and sent it back. And then during my chief year, they started calling and say, hey, you're about to graduate, coming on active duty, let's start talking about where you're going and that sort of thing. As far as the 4 years in reserves, technically while I was here for 5 years, I was in the inactive reserves, and so that ended up counting as my reserve time. And so once I finished my 4 years of active duty, I was done. And so I just turned in my resignation papers, resigned my commission, and so I'm out now, can't be caught up. It's just, I did it, thank you very much, and on with life. So my time in the Navy, I spent the first 3 years on Guam, which is a little island a long way away, and I got a map here in a second. There were 2 orthopedists there, or 2 military orthopedists. There was a couple out in town that I never even met, at a third world hospital with old school gear. I think they're still using stainless steel nails. That's whatever they left on the shelf. And we actually had a relatively large patient population to just be 2 of us. There was about 20,000 active duty military personnel and their dependents, wives, kids, between the Air Force base and the Navy base. But in addition to that, all of the Guam Army National Guard people, retirees, families, were eligible for care at the military hospital, and all the VA population. So we had a relatively large patient population. The island itself is about 170,000. I did pretty much everything but arthroplasty and spine. Again, as y'all know, if you don't do spine, you don't do spine. And we just didn't do joints there because there were patients that needed them, but not enough to have everything you need to kind of support arthroplasty. Took part 2 of my boards while I was there, so went through case collections there, and then flew back to Chicago for boards. So where is Guam? I didn't know either until I started looking at going there. So this little dot over here is Hawaii, or the end of the arrow, and so it's 4,000 miles past Hawaii. The closest, decent land mass, I guess, is Papua New Guinea. I think Japan was about 1,500 miles. The Philippines were about 1,500 miles. Anyway, point is, long way away, very remote, and you were literally on an island out there. When I was there, it was the only hospital in the Navy that actually gets direct trauma admissions, because most of the other naval hospitals are in bigger areas. For example, Pensacola, there was a level 1 trauma center in Pensacola, so you're not going to get any trauma there. But on Guam, we were one of 2 hospitals. The other one wasn't even accredited half the time, and so we got trauma both military and civilian. Basically, if you were on the southern half of the island and you got hurt, you went to the naval hospital. And if you're on the northern half, you went to the other one just because they were closer. And I tell you to say this, you're not sure where you're going to end up when you leave here, and so you have a great opportunity here for doing trauma, and I would say do as much as you can and don't forget it, because you never know when you may be doing this stuff again. The situation I was in, for example, I remember for sure X-fixing 2 pelvises, putting in traction pins. I remember one time there was a group of Army Special Forces guys that had come over from Hawaii that were doing some training. And y'all be able to appreciate this. I'd gotten to be friends there with, went to church with him, a Navy SEAL. There's a small unit of SEALs on Guam, or at least there was when I was there. And he gave me the heads up. I was on call. He's like, hey, I don't know if you're on call or not, but we were doing some training, and this Army guy just fell about 40 feet off the top of this water tower with all his gear on, so he's probably broken. Of course, then you're just waiting for the phone call. And then, he had a bad vertical shear pelvis, which I wasn't really qualified to fix. But yeah, you were.
I'd seen him before. I knew what to do. I just didn't feel comfortable doing it on this Army SF guy. Was like, I got to stabilize this guy because the closest place is 4,000 miles away. I mean, that's where he's got to go for definitive treatment. So
me and my partner, anything bad like this, we'd always kind of double scrub it just because nobody else in the room knew what was going on. X-fix his pelvis, put in a femoral traction pin, and tried to get him ready to go. Of course, then the guys that run the C-130 are like, oh, we can't have these weights hanging off the end of the bed, for the traction. I'm thinking, well, you gotta find a way to keep some traction on this guy's leg because he's got an awful injury. Anyway, I had multiple extremity patients. I remember one girl was junior, senior high school on her way home from studying at a friend's house and runs into a light pole and's got bilateral femurs and an ankle and a wrist and all this stuff. So, gunshots, they had an X-fix with vascular injuries. I did tailor body neck combinations. I did BKAs, and there were no reps at all on the island. So they had one Synthes rep on Hawaii that we saw about 3 times a year. Other than that, you were it. So, point is, do what you can and don't think I'm never going to do this again because you never know if you will or not. Another thing I would encourage you to do is wherever you end up, especially if you are doing fellowships and traveling around or whatever, take advantage of the opportunities you have there. Guam gave us a unique opportunity to travel over that part of the world because it was closer to there than it was to come back home. So we went to Australia twice, Japan, Thailand, had an overnight in Manila, Cambodia, had a 13-hour layover in Seoul, South Korea, going to Cambodia, and had a toured Seoul, and then went to China. So one of the main reasons I don't, one of the best things for my family about the Navy was the opportunity it gave us to go places and see things and do things that otherwise we wouldn't have done. That's my daughter with one of those, you've probably seen those long neck folks in the hill tribes in Thailand. Actually said if they take those things off, they die because their muscles are so weak they can't hold their head up, and their airways they can't keep their airway open because their head falls over. So I think they had to decide when they were young, teenager, if they're going to do the rings or not, and once you commit to it, you're doing it. That was at Angkor Wat in Siem Reap, Cambodia, and that's on the Great Wall. So Terracotta Warriors. So anyway, take advantage of the opportunities you get because you will get some wherever you are, or if you just go somewhere for a year for fellowship. Do what you can while you're there because it's a long journey and enjoy the journey. So after my 3 years on Guam, I did my last year in Pensacola. This was basically my prep year for getting out of the Navy because I knew I was going to get out after 4. You got to do 20 to get a retirement. When you sit down and do the numbers, doing 16 more does not make sense. And I was just wanted to be able to settle down in one spot with my family. So in Pensacola, there were 5 orthopedists there. We had a hand upper extremity guy. There was no ER at Pensacola. There had been until basically right about the time I got there. And they ended up shutting it down, just making an urgent care center, which closed at 8 o'clock. So call was great because once 8 o'clock came and went, if you didn't get anything by then, you weren't going to because there's nowhere to call you. We did have reps there, so I was kind of dipping my toe back into the real world, having, being able to see new gear and get people to bring stuff in. And I mentioned earlier, did not do any arthroplasty on Guam. We do the occasional hemi for a hip fracture, but that was maybe a handful a year. And so my year in Pensacola, I spent time, knocking the dust off my arthroplasty skills to get ready to come out into private practice. Another point there, while you're here, to the extent that you're able to, and I realize you don't get to choose a lot of the stuff, but try to get familiar with as many different implants as you can. When I was here, we had guys doing Stryker, guys doing DePuy, the occasional Smith & Nephew, some Zimmer. In Pensacola, we were using primarily Stryker for that year. Now it's Smith & Nephew, but it's just always one less thing for you to be anxious about when you're doing stuff on your own when you get out if you've seen the gear before, whether that's trauma stuff. I know here we're mostly Synthes, at least we were, assume we still are. Had Synthes stuff in the Navy, but I know buddies who are a couple years behind me. Brock Howell's in Montgomery, and his hospital's contract is with Stryker, and so he can't even do a TFN if he wants to, so he's got to use a Gamma. So to the extent that you're able to, at least try to get your hands on some other stuff, just so you have seen it before, because that maybe end up being what you're using. So in summary for the Navy, it was a great learning experience for me. From a practice standpoint, there was no pressure because I was getting paid the same whether I did 1 case a day or I did 5. Didn't matter how many patients I saw in the clinic, because you could really, it's not a system set up for efficiency. You could only see so many. And so it was a good chance to kind of learn, hone my skills, get comfortable and confident as a, as a surgeon before I came out to the real world. Had some great experiences, made some great friends in the Navy that I still stay in touch with. From a financial standpoint, came out of the Navy, or actually left residency, totally debt-free, no student loans to pay off, nothing like that. And for me, the way it worked out, it's because of the Navy, I kind of got into running and triathlon, which I continue to do to some degree, depends on the year, which for me is a good stress reliever and a good way to stay in shape and that sort of thing. And honestly, I never ran until my last semester here, and I knew I was going in the Navy, and I knew I was going to have to pass the fitness test, which is just a 1.5 mile run, but I couldn't tell you the last time I'd run a 1.5 mile. And so I thought I better start running, get in shape, or I'm going to fail this test. And so that's why I started running, but I got on Guam, since it was summer year-round, I mean, we'd be swimming in, swimming in the ocean in January, and we just kind of, there was an endurance sport community there that I got into and enjoyed that stuff. But anyway, so that's my Navy time. Obviously, it's too late for y'all to do what I did because you've already graduated medical school. They do have a financial assistance program where if you were interested as a resident, especially the younger guys, they have a program where they basically give you a check for $45K, about $2,200 a month for a stipend, and I believe that's in addition to what you get paid by UT. And then the obligation is a year for a year plus one. So if you do that for 2 years, you owe 3. There may be a 3-year minimum obligation. I can't remember, but if anything I said has piqued your interest, and I know Dr. Notarski did the Navy as well, then I can answer any more questions upstairs if you want to talk any more about that. All right, so where am I now? After getting out of the Navy in July of 2015, I moved back to Jackson, which is my hometown. Joined the group, West Tennessee Bone and Joint. Several of the guys in this group are the ones that got me interested in orthopedics to begin with. Background, my dad's a CRNA, and so some of his friends when I was growing up were some of the guys that are now my partners. And so that's how I got exposure to orthopedics. And so I said, well, being young and naive, I'm going to do that when I grow up. They're nice guys. We have a lot in common. We hunt together and fish together and watch football together. And at the time, I was cutting their grass. And they make a good living, so I think I'll do that. And so my agreement as a new employee, and we can talk about details more upstairs if you want, but employee for 2 years, and then if they were happy and I was happy, the opportunity for partnership, and then there's a buy-in involved with that. Our practice, we have, I guess, all the ancillary services. We got a PT department, MRI scanner, obviously in-house X-ray. We have recently got a extremity CT scanner, DEXA scan, DME, all the braces, all that stuff, ultrasound machines. In total, our practice, we got 14 surgeons. One of them is a general surgeon who did a hand fellowship, so he's only hand. We got 2 guys that are semi-retired, where they're just kind of doing office stuff only. They don't operate anymore. We got 1 interventional pain management guy, and got another one starting in January, and 1 podiatrist that's not in Jackson, but he's in the area. Got another guy coming next summer when he finishes his sports fellowship, and then needing a foot and ankle guy, we got 1 that may be coming in 20. We're at 11 different locations overall throughout West Tennessee. Our main office is in Jackson, but we do satellites all over West Tennessee. Basically, we try to capture every patient between Memphis and Nashville. And then our group is part owners in the name of it's a physician surgery center. It says independent surgery center. It's not affiliated with a hospital. And the ophthalmology group, and then there's a management group that owns the rest of that, and we're in the process of getting the management group out because we figured out how to do it ourselves, and they're just sucking up profits now and contributing nothing. So I have 2 LPNs that are my employees full time. One of them is in the office every day. Obviously, when I'm in the office, she helps me with workflow and patient flow. When I'm not there, she's working on getting pre-certs for MRIs, getting surgeries approved, returning patient phone calls, doing all that stuff that has to get done by somebody that you don't want to do and don't have time to do. And then my other LPN he basically goes wherever I go. So when I'm in the OR, he's in the OR. When I'm on call, he's on call. When I'm in the office, he's in the office. I've taught him how to close, put on splints, do my dressings. If we got to reduce a risk in the ER, I call him. He beats me there. I get there, and he's in the room with the C-arm set up and splint laid out and ready to go. People like that are worth whatever you have to pay them because it's a quality of life issue, and we'll go over that some too. And all the stuff that you're having to do right now, it's just work for you. You've learned how to do it. At first, it's kind of fun and exciting, but after you've done 100 of them, it's just more work. And if you can get someone else to help you with that stuff and make your life easier, it's worth it. Also have a scribe that works primarily for me. When I'm not there, she may help out one of the other guys. And that's another thing that I feel like has made my life huge because all I do is I look at the x-ray, tell her what it looks like. I walk in the room, she follows me. I talk to the patient, examine the patient, and walk out and see the next one. Like, note is done. She's got her iPad and she's plugging away while I'm doing all that. And when I'm done for the day, see my last patient at whatever, 5:15, 5:36, depending on the day, then I'm done. I don't have to stay for another hour, hour and a half dictating. And I know people that still do that, and one of my classmates, Hester, has done that, and he's actually left his first job because he was staying until 8 or 9 o'clock every night just getting hammered. Anyway, I do 2 different satellite clinics. One of them is 1 half day a month, so it's not that often. The other one I do kind of every other Thursday afternoon. The once a month one's about 45 minutes away. The every other week one's only about 25 minutes away. Most of the guys just have one. I may donate one of mine to the new guy that's coming next year, so I can get down to 1 instead of 2. Typical week for me, and again, we have satellites every other week or so. It varies to some degree, but typically 2 days of office a week, 2 days of surgery a week, and a day off. All right. I don't always have a day off every week. Sometimes you got to do cases and things just need to be done, and I'll go do a case or 2 on the day off. Honestly, I don't mind going to fix a simple fracture or 2, be done by 10 o'clock, and be off the rest of the day. Because realistically, when you got kids in school and a wife that's working and doing other stuff too, well, I mean, what are you going to do? But what that day off does is it gives me the flexibility to do things like this. Like last week, for example, I can't remember what my day off was supposed to be, or this week either. Once Jeremy talked to me about coming to talk, I already had plans to go to Athens for the game on Saturday with JP. He was a year ahead of me here. And so I shifted my schedule around. So Friday was my day off last week. Monday's my day off this week. And so I got a 4-day weekend. I'm not missing any work, which is nice. We got 10 guys that are in the car rotation right now. So one weekend every 10. We do Friday to Sunday, which is pretty sweet. I know you seniors think, when I remember going from Q3 to Q6 was a big jump. Q10 is even better. Some months I may only have 1 or 2 call days, just depending on how the rotation works out. If it's one of those months where I got 5 or 6 days, that's because 3 of them are a weekend and maybe a couple other scattered ones during the week. We do get paid for taking call when we're on trauma call for the hospital. Now there's another group in town, and sometimes they're on trauma call, but we want to call for the group, for my group, but we don't get call pay for those days. The hospital, the primary hospital in our town is, it's a pretty big hospital. I guess technically it's level 3 as far as trauma, but it's got 700 beds, gets about over 100,000 ER visits a year. A lot of, West Tennessee is fairly rural, and everything pretty much gets shipped to Jackson unless it's really bad and has to go to Memphis or Nashville. And so we get a whole lot of, a third of the state. We do get some trauma. I fixed the plateau last week. We get pilons, elbow stuff, paraarticular stuff, open injuries, some ped stuff. So again, don't forget your training. Even at a level 3 as a generalist out in town, I'm still doing this stuff. Got a big group message chain with a bunch of my buddies from here that were a couple of years up and a couple of years down. They're out in practice. Some did joints fellowship, some did sports. Whatever they did, everybody's seeing this stuff. So you're going to have a pretty tailored practice and not take call if you think you're going to realistically get out and never have to fix anything again. pay stuff, we can talk about it upstairs more if you want to. Basically, I get a paycheck every week, I have a salary that's set for myself, and then I get a bonus every quarter based on what I brought in that's beyond my expenses, in a nutshell. We can go over that more upstairs if you have any questions. So office, templates for 50, 25 per each half day, sometimes more, usually less. There's always some that don't show up. My satellites are just half days, so 25 max there. Don't forget, try to learn the office stuff. I know when you're here, you're really focused on learning surgery because we're surgeons and that's what we want to do. I always tell people if I like the office stuff, we do family practice. But the reality is you're going to spend half your time in the office, most likely. And it's also where surgery comes from, with the exception of the trauma guys. It just kind of comes to them. But if you're doing anything that's elective, you've got to meet the people. You got to, get to know them. You got to figure out if they need surgery, and then and do it. And so you're going to be there a lot. And there's a lot of things that you see in office that you don't see. We're joking about it last night. Like you see somebody comes in with something, and you're like, why am I seeing this? This isn't surgery. I don't need to see this. But the reality is you are the musculoskeletal expert, and people are going to send stuff to you. I can't tell you how many ankle sprains I see a week in the office. You're like, it's an ankle sprain. Why does it even need to be here? Well, it doesn't need to be here, but the patient doesn't know that. Give them a brace, send them to therapy, see them back in a month, make sure they're doing okay. And that builds your practice, because the next time when that person, if they like you, again, that's bedside manner is the next point, be friendly to people. Treat everyone as if their problem is serious, even though whether you think it is or not. Because if they like you, when their mom needs a total knee, who should I go see? Oh, I saw Dr. So-and-so, go see him. Whatever. I mean, word of mouth, that stuff counts. And I know here you do office maybe a half day a week, and there's not a lot of continuity, you don't get that, but try to pay attention in office and pick up some of that stuff. Learn what's normal. Okay, does this wound supposed to look like this 2 weeks after surgery? Because I remember as a resident, you assume everybody does great because you operate on them, you close them up, and you never see them again. Well, everybody doesn't do great, believe it or not. And that's where spending some time in the office, you realize that. And okay, how bad do they got to be before I go looking to see if we screwed something up? What do I do with this wound that may still be draining a little bit? It's easy to learn it hypothetically, but in practice it's a different thing. And so I would encourage you to don't just blow off your time in the office or the clinic, because it is important, and you will be spending a lot of your time there. And honestly, a full day in the office is even from a financial standpoint, it's just about as productive as a decent day in the OR. All right, so what do I do right now surgically? In a nutshell, everything but spine. Arthroplasty, I do total knees, do some medial unis, total hips. Don't do total shoulders. Only saw a handful of them when I was here. Nobody was doing a bunch of them when I was here. And I just don't see a lot of patients that need it. I have one partner who's likes shoulder stuff, and he's kind of tailored his practice to be the shoulder specialist. And so on the 2 or 3 patients a year I see that actually need a total shoulder, I just send them to him. If I was seeing a bunch of them, I'd figure out how to do it, because I figure if he can do it, I can too. But right now, as it is, my patients are better off with somebody who does 10 a month than somebody who does 3 a year. So I just send them to him. All the sports stuff, cuffs, bank cards, ACLs, MPFLs, and then just debridement stuff. Hands, primarily as far as elective stuff, carpal tunnels, triggers, the occasional DeQuerre veins, foot and ankle. I'll just kind of do a scope debridement. That's about the limit of my ankle arthroscopy. Put a camera and clean some stuff up. Maybe use it for a fusion if I'm doing one of those. I'll fix some list franks, typical trauma stuff. And then, trauma stuff, like I said, we have a fairly busy hospital. Fix just about everything if it's not too bad. Now, if I get absolutely dusted P-line or plateau or whatever, I'm going to X-fix it, call one of the trauma guys we know in Memphis or Nashville and send it to them. Not because I haven't done it or because I think I can't do it, but because, again, for the patient, they may be better off with somebody who does this several times a week at a trauma center versus somebody who's done, oh yeah, I did one of these 8 years ago. I think I can do it. I probably could, but it might take me way longer than it should, cause me much more stress than I want to put up with. And when you get in practice and you have an elective schedule, where are you going to carve out time to spend 4 or 6 hours on some awful articular fracture? You know how to stabilize it and send it to them, you know, semi-elective, and generally they're okay with that. Again, I've said it before, I say it again, remember your training, you'll be doing this stuff. So what do I do differently now, or what do I do, period, that I never did before? ACL technique has evolved. When I was here, we were working primarily with Dr. Tu, and he did transtibial, so I started off doing it that way because that's what I knew. Then I kind of moved over to the intermedial portal using rigid reamers just because that's all I had on Guam. And then once I got back to the continental U.S., intermedial portal with flexible reamers, and now I'm doing outside in. Graft choices, again, when I was here, everybody did, or Dr. Tu did allograft hamstrings, so that's what I did leaving because that's all I ever saw. And that was kind of a one-trick pony. On Guam, we did not have allograft, and I'd never taken a BTB, and so it was everybody got hamstrings. And if they were too small, then it was just to be careful because I got nothing else for you. We did eventually get some allograft, and so I may get a hybrid every once in a while. Throw a, use their CMT and pull a CMT out of the freezer. Last few years, I've learned some of the techniques using hamstrings again, where you triple both of them, which makes big and long enough, or quadrupling a CMT, the Arthrex and Graft Link stuff. I don't know if we're supposed to mention companies by name, but no disclosures. I don't get paid by anybody. I still don't do any BTBs. Again, I never saw it in training. I have some partners that do only that, some that pick and choose. My take is kind of, if it ain't broke, don't fix it, and there's still not a clear advantage to one over the other in the residency, in the literature, so I just keep doing what I do. In PFL, I do not a ton, but I don't see a ton of patients that need it, but I'll do several a year. I did one a few weeks ago, got another one coming up. Medial unis, never saw one in residency. I do a decent amount of those and have been pleased with that. I've started doing total hips anterior, which I never saw here. I guess we learned about the anterior approach, but it was in relation to ORIF or a femoral neck, which you don't do we didn't even here. We didn't do a ton of femoral neck ORIFs. As an intertrochlear nailed or hemi and you fixed it, and you have the occasional trauma, a young person, and to do that. But anyway, so kind of self-taught on those. We got call it a robot. I don't know how accurate that is, but about a couple months ago in Jackson, we got the Navia, which is a Smith & Nephew version that we can talk about more later. So started doing some of that sending total knees. Almost all my unis go home. Pretty much all my unis go home the same day. I did a total knee at our outpatient surgery center a few weeks ago. That's the first one that ever had been done there and gone home. When I was here, and I'm sure this is the trend everywhere, and we're probably even a little bit behind in Jackson because there was a lot of places that are doing outpatient total knees routinely. But when I was here, we didn't do that. They laid up on the floor with a PCA pump, worked out for a couple days, and you're hoping to get them home on day 3. The wrist spanning plate, which I don't know if they're doing or not. I'm sure you've seen it, heard of it, for just as awful comminuted distal radius fractures instead of X-fixing it. Done that a couple times, not a bunch, but it's worked pretty well for that. And then use ultrasound for injections now, which enables me to do hip injections and things like that in the office that you can't do blindly. Where do you learn these things? Obviously, you hear about it in journals and read it and make sure it's something that's legitimate and you want to learn. Go to courses. Pretty much all the companies, especially once you get out, are happy to take you to a weekend and wherever, Nashville, Birmingham, whatever's close to you, for a little 2-day course on something, because obviously they want you to use their gear, but that's also where you learn how to use it. Colleagues, friends, y'all have lots of colleagues here that all of you are going to do something different for the most part. You probably have somebody that does arthroplasty, that does sports, that does whatever. stay in touch with each other. And I heard it, I'm pretty sure here, you won't be the first one to do something, but you won't be the last either. So, pay attention. If you see some article that's something that sounds great, but it's the first time you've ever heard of it, sit on it for a little bit. Wait till some more articles come out. Make sure it's going to stand the test of time. It's not going to have a super high failure or complication rate. And then once it's kind of been proven, you may as well jump on board because everybody else is going to be doing it. And then get some help. When you're trying new stuff, doing new stuff, grab a partner. Say, hey, I'm doing this. Somebody else maybe is thinking about doing it. I know we did that because there's really 3 of us now in my group that are doing anterior hips. Everybody in my group trained posterior just like I did. That's all we did here. And people started asking for anterior hip. Patients would call and ask, hey, do you have anybody doing anterior hips? And at the time we did. And so we're like, well, this is, and then talking to the guys who are like Higgins and Brock and Doty, that group, the behind me that all did arthroplasty fellowships, and they're like, yeah, that's all we did in fellowship was anterior hips. And so I can see the writing on the wall. If that's all they're doing in fellowships now, before long it's going to kind of be standard of care, or certainly commonplace. And I'm still young enough and early enough in my practice, like, look, if I don't get on board with this before long, I'm not going to be doing any hips. And so there's 3 of us that decided we want to learn how to do it. And we went to some courses and read the books and watched the videos. But at some point, you just got to jump in. But all of us, for our first few, we double scrubbed them. And it's not so much that you need another set of hands. You know how to make your hands work. You just need another brain to say, yeah, that looks right, or no, that doesn't look right, or is this the right interval for that dissection when you're getting started out and that sort of stuff. So you can work that out. And I would say if you don't have that kind of relationship with your partners where somebody's willing to help you out, then you probably shouldn't join that group anyway. If somebody can't take a few hours out of their day to help you out, to help you develop your skills and do what's best ultimately for your patients, then you may need to look elsewhere. Along the same lines, like I said, stay in touch with each other. There's always going to be something you haven't seen before or done before and you don't know what to do with it. All right, this still happens to me. I mentioned when there's a group message with about 7 or 8 of us, all from Chattanooga, and almost daily somebody sends a picture of an x-ray, puts forward some scenario. What about this? Never seen this. What do y'all think? Everybody chimes in. It's fine. It's not a sign of weakness because ultimately it's your responsibility to your patient because after you leave here, they are your patients. Right now they're Dr. Tu's patients, Dr. Alvarez's patients, Dr. Bruce's patients. Once you leave, they're your patients. And you and that patient are going to have to live with the consequences of what you do to that patient and if something goes wrong. And so you owe it, number one, to yourself, so you feel confident doing it because you want to get the satisfaction of knowing you did a good job and things went well. And 2, you owe it to your patient. And so ask. I remember when I was on Guam, and it was tricky on Guam because there's a 13 or 14-hour time difference depending on if you're on daylight saving times here. I called Connor several times. I called Dr. Alvarez several times. Like, hey, I got this. I'd take pictures, and this is, I guess, I'm trying to think. I think I got my first iPhone on Guam, but it wasn't my first year. But I remember somehow I sent images. Connor, I don't know if I made a PowerPoint, emailed it to him or what, but I was like, hey, this is what I got, this is what I'm thinking. Does this make sense? He's like, yeah, it sounds good, And then same thing with Dr. Alvarez. I remember I had one patient had subluxing perineal tendons, which I learned about in residency. I may have seen it, I may not have. But I knew what it was, and I knew roughly how to fix it. So I remember calling Dr. Alvarez, hey, that's kind of what I was thinking. He gave me some tips, some tricks. And so, and then obviously Sierra and I were classmates. I called Doty about a month ago about a foot case. Brock did a joints fellowship. Hester's, we graduated together. He's generalist, but he's just worked his butt off and seems to have done everything. Just ask him. Then Shane was a year ahead of me. Also generalist, but got a lot of experience doing stuff. Jeremy and Rose both did sports. Dunn did joints, and Carlos Kennedy was one of my partners in the Navy who did a trauma fellowship. I forgot the Navy, but anyway, the point is maintain these contacts. Don't be afraid to use them. And then locally in my area, like I said, there's Jackson's 80,000 people. We got a big referral area, but we don't have every specialist. We don't have a tumor guy. I know the tumor guy in Memphis. I can send him there. He'll take him. Trauma guys, same thing. We usually have more luck getting folks sent to Nashville for trauma. They're just more accepting. I think the guys in Memphis are just so hammered. They don't care if they have insurance. They don't want more work. More at Vandy, they're more friendly and willing to take stuff. Same thing for spine. We don't have a spine surgeon. And so maintain contact with your people to help you with your practice, but also know where to send them in the event that it's something you can't take care of. So this is primarily the crew from when I was here that I remember. That's Hester. He was my classmate. JP's a year ahead of me. He did spine fellowship. I just spent the weekend with him in Athens for the Tennessee game. Corrigan is in Wichita. Yeah, I knew it was somewhere in the Midwest. Higgins, you know. Bruce, you know. Arnold's here in town. Denhan. Mike's doing foot and ankle in Birmingham. There's Dr. Doty again with a razor. Asbury is in Maryville, Tennessee. You know, Sincere. There's me. Rhodes and Dunn are both back in Georgia, sports and arthroplasty. So this was kind of a year up for me, and the years down. I think this was probably JP and Justin and Shane's graduation deal. Last but not least, when you're looking for a job, finding a job, life is not all about your job. I know you've spent your whole academic career, scholastic career, whatever, getting to the point of getting out and getting this great job. And it is a great job. I enjoy my job. I like the people I work with. I enjoy my patients, and it's nice to be able to help people. But it is a marathon, not a sprint. Right now you're rushing to get done. Well, once you get done, you're just done. And work is work. And just like a lot of what you do now, things that at one time are fun and exciting, at some point they're going to become routine. There's always going to be some challenges, and I think there should be. But don't forget about quality of life. Don't sacrifice that for money. You're going to make plenty of money. Is there a difference in $500 and $7,000? There is, but at what cost? I know Hester, my classmate, when he was in Georgia, I know his last year there, he said he made more money than he ever made, but he said it wasn't worth it. He never saw his family. He's got young kids. He was getting home at between 8 and 10 o'clock every night, and he was just getting absolutely hammered. He's like, it's not worth it. And so he left. Took a job making much less money, but he's much happier. Location, and this all goes into it. You know, you want to find the right job. It needs to be in the right place too. You know, do you want to be close to your family, or do you want to be far away from your family, or your wife's family? But these are all things that are going to play into your overall satisfaction with life. You know, if you've got young kids and you're closer to family, either your parents or wife's parents or whatever, it's nice to have babysitters that want to take care of your kids and don't charge you. Like I said, I moved back to my hometown after I really haven't been gone for 18 years, I guess. I graduated high school in 97, moved back in 2015. First time we'd ever lived in town with any family, and it's great because my parents can keep my kids if I want to take my wife away for the weekend. Is also, you know, my dad's a CRNA. He's still working. So my first case back in town, Dad did anesthesia, which was pretty cool. And I mentioned running earlier. I think it's important for me. You'll find even though when you get out, technically you're the boss, you really don't have near as much control as you think you do. Because in the OR, you still are waiting for anesthesia to put them to sleep. You're waiting for the scrubs to open the gear. You're waiting for the cleaning people to clean the floor between cases so you can turn over. And so you don't have, and even in the office, patients got to show up. Then you got to wait for them to get x-rays. You got to wait for them to fill out paperwork. And so technically you're the boss, but you still don't have that much control over your day. For me, I go for a run, don't take my phone, take some music, and I'm in total control for that hour. I can go as fast as I want to go. I can go as slow as I want to go. I can walk. I can not go. But either way, it helps clear my head. If I got a big case coming up, I'll think about what's coming up. And it can be the gym or swimming or whatever. But the point is, I think doing something is good for you. Not only physically, it's a stress reliever, but it kind of gives you a chance to just kind of get ready for the day or finish the day if you're an evening exerciser. Don't forget about your family when you get out and start working. Your patients do need you. Lots of patients will need you, and you can help lots of people, but they don't need you like your spouse and your kids do, because it goes by quickly. My daughter was born when I was here. Second year, August, trauma. Me, JP, and Matt Willis. There was 3 of us. Willis was the chief as a new 3. Dr. Noah Tarski was the only trauma guy because Dr. Conner hadn't gotten here yet. Noah's head was spinning because it was August and we were getting absolutely hammered. Like, our list was like 3 pages, like 30, 40 patients on the service, and he had a new 3, a new 2, and I guess I was.
Willis had his surgery and took the whole rotation off.
But anyway, so that's when my daughter was born, and she's 11 now. What was that?
I'm just telling him the surgery worked.
Oh yeah, and she's 11 now. So the point is, it goes by quickly. Don't get so busy working that you miss that stuff. You know, my son was 18 months old when we moved here, and he's 13 now in 8th grade. And along those lines, when you're going to look for jobs, and I mentioned it earlier as far as my practice, pay attention to call frequency and volume. It's one thing to be on call, but if you're just somewhere really rural and it's not that busy and you don't get anything, but they may call you about a risk that could follow up in the office, big deal if you're on call 10 days a month if that's all you do. But if you're getting hammered on call, like we do sometimes, you don't want to do it that often because you still got an elective practice you got to do. There are no duty hour or work hour restrictions in the real world, and so even if you operate until 1 or 2 a.m., you still got work the next day if you got stuff scheduled. You can't, I'm going to take off at noon tomorrow. And so pay attention to that stuff and really find out what it's like before you agree to go somewhere. And then finally, take some time off. You know, take a trip, go somewhere, do something. Taking a week off is not going to kill your practice, but it's really good for you and your family. Enjoy life. You worked hard to get to this point. It's a great job. You're going to make enough money. Just go do something fun, you know, several times a year. You know, take off a week every quarter or whatever. You can afford it. And going back to it being a, you know, marathon, or if we're going to use the triathlon analogy since the Ironman was here, State's an Ironman, you're going to get burnt out if you just go hard and don't stop year round. Yeah, you may make a ton of money, but, you know, it's you gotta enjoy the ride. And this is what you're working towards, so don't take it too seriously. Summary, basically all the stuff I've said multiple times. Do as much as you can while you're here, and don't forget it. Use as many different things as you can, because you never know what you're going to get where you go. Take advantage of whatever opportunities you get. Don't blow off the office, because it's half your practice once you leave here. Keep learning. New things will come along. It's only been 7 years since I graduated, and there are so many things I do now that I never did here, and things I do differently. And I'm just a generalist in West Tennessee. So pay attention, keep learning. Stay in touch with each other and the connections you make at fellowship or whatever, and then keep it all in perspective. So that's all I got.